Dennis Farber retired from his accounting job in Phoenix, Arizona at 64 and a half. 31 years with the same employer. Good coverage, no major claims. He figured he had nothing to worry about. He was 6 months away from Medicare. He knew that. He planned for it. What he did not plan for was the letter his HR department sent him 1 week after his last day of work. Cobra coverage, it said. 18 months of continuation coverage available. He signed up. He paid the premium every month. He figured that bridged him to 65, and Medicare would take over from there automatically. It did not work that way. When Dennis turned 65, he assumed Medicare enrollment was automatic. He had been paying into it for 31 years through every paycheck he had ever received. He assumed there was some process in motion, some form that got filed, some card that showed up. There was a process. He had already missed it. The enrollment window he needed had opened 3 months before his birthday and closed 2 months after it. He was outside the window, not by years, not by months, by 6 weeks. Dennis Farber is now 81 years old. He pays a Medicare Part B late enrollment penalty on every single premium, every month. For the rest of his life, his insurance company never told him the window existed. My name is Clint Reeves. I spent 19 years as a senior claims examiner and utilization review specialist at 2 of the largest health insurance companies in the United States. I reviewed tens of thousands of claims. I sat on denial review committees. I trained new adjusters on how to read policy language in ways that reduced what we paid out. In 2021, I walked away. There are 7 things your insurance company expects you to figure out on your own before you turn 65. Not suggestions. 7 facts built into federal law and private insurance policy language that determine what you pay, what gets covered, and what you lose permanently if you miss them. Most people turn 65 without knowing any of them. By the end of this video, you will know all 7. Let us start with the one that cost Dennis Farber 17 years of monthly penalties and counting. Number 1, the enrollment window is not automatic, and missing it costs you money every single month for the rest of your life. The most common assumption among Americans approaching 65 is that Medicare enrollment is automatic, that the government tracks your birthday, does the paperwork, and sends you a card. That is only true for one group of people. If you are already receiving Social Security retirement benefits before you turn 65, Medicare Part A and Part B enrollment happens automatically. A red, white, and blue card arrives about 3 months before your birthday. If you are not yet receiving Social Security, nothing happens automatically. You must actively enroll. You have a specific window to do it in. And if you miss that window, the consequences are permanent. The window is called the Initial Enrollment Period. It runs for 7 months. It opens 3 months before the month you turn 65. It includes your birthday month. It closes 3 months after. 7 months. One window, no extensions, no second chances at the standard rate. Miss that window and you must wait for the General Enrollment Period, which runs January 1st through March 31st each year. Coverage under General Enrollment does not begin until July 1st. That gap can mean months with no coverage at all. But the penalty is the part that follows you. For every 12-month period you are eligible for Medicare Part B and did not enroll, your monthly premium increases by 10% permanently. There is no forgiveness process. There is no standard appeals path. That surcharge compounds with every year you delay and stays on your bill for as long as you live on Medicare. Dennis Farber missed his window by 6 weeks. He has been paying a permanent premium surcharge for 16 years. At current Part B standard premium rates, that surcharge adds over $400 to his annual costs every year until he dies. Why would your insurance company not tell you this? Think about it plainly. As long as you stay on their plan, they collect your monthly premium. The moment you move to Medicare, they lose you as a paying customer. The business incentive to explain your exit window has never existed for them. Find the month you turn 65. Count back 3 months. That is when your window opens. Set a reminder. Tell your spouse. Tell your HR department. Do not assume anything is happening automatically. Number 2, if your employer has fewer than 20 employees, staying on their plan past 65 is not an option. It is a trap that can leave you with a 6-figure hospital bill and no coverage. Most people approaching 65 who are still working believe they have a straightforward choice. Stay on employer coverage or move to Medicare. Both options are valid. You can decide when you are ready. For employees of large companies, those with 20 or more employees, this is essentially true. Large employer plans are required to treat Medicare-eligible employees as they would any other employee. Your employer plan pays first. Medicare is secondary. You can delay Medicare enrollment without penalty as long as you have that qualifying employer coverage in place. But if your employer has fewer than 20 employees, the rule reverses entirely. At companies under that threshold, Medicare becomes the primary payer. Your employer plan is secondary. Here is where it becomes a trap. Most small employer insurance plans contain a coordination of benefits clause stating that the plan will not pay for services that Medicare should have covered first, but did not, because the member failed to enroll. In plain language, if you are 65, working at a small company, carrying their insurance, and not enrolled in Medicare, and something serious happens to you medically, your employer plan can deny the entire claim. Not a portion of it, all of it. Patricia Mendez worked for a family-owned dental supply company in Albuquerque, New Mexico. 18 employees. She turned 65 in March. She kept her employer coverage because she was still working and saw no reason to change anything. No one at her company told her the rule. Her insurance company never raised it. She had a cardiac event in October of that same year. 3 days in the hospital. $112,000 in bills. Her employer plan denied the claim. Medicare was primary, they said. Medicare was not enrolled. The plan had no obligation. She paid $38,000 out of pocket before a state insurance attorney helped her recover a portion through a complaint filed with the New Mexico Office of Superintendent of Insurance. The process took 2 years. The recovery was partial. Her employer did not know the rule well enough to explain it. Her insurance company knew it and said nothing. Ask your HR department one question right now. How many employees does this company have? If the answer is under 20, you need Medicare the moment you turn 65. Not as a backup, not as a supplement. As your primary coverage, this is not a preference. It is a federal rule with real consequences. Number 3, your current prescription drug plan may not qualify under federal standards. And if it does not, a penalty follows you permanently into Medicare. Medicare Part D covers prescription drugs. It is technically optional. You can choose not to enroll. But there is a condition on that option that most people do not understand until they are already paying the price for it. If you go without Part D coverage, or without what the federal government calls creditable drug coverage, for 63 or more consecutive days after you first become eligible at 65, you trigger a late enrollment penalty. That penalty is 1% of the national base beneficiary premium for every month you went without creditable coverage. It is added to your monthly Part D premium permanently. Creditable coverage means your current prescription drug plan covers, on average, at least as much as the standard Medicare Part D benefit covers. Your employer plan may qualify, it may not. Your insurance company is required by federal law to send you a notice every year telling you whether your coverage meets the creditable standard. Most people receive that notice and throw it away with the rest of the insurance mail. They assume all employer coverage is creditable. It is not. Employer plans with high deductibles, limited drug formularies, or benefit gaps can fail the creditable coverage test while still functioning as regular health coverage. Robert Haynes was 67 when he first enrolled in a Medicare Part D drug plan. He had been on his wife's employer plan since he turned 65. He assumed, reasonably, that her plan's drug coverage counted. It did not. Her plan had a mid-tier benefit structure that left a gap in the coverage design wide enough to disqualify it under the federal creditable coverage standard. The notice had come every year. He had never read it. Robert now pays a permanent Part D penalty surcharge of 22% on his monthly drug premium. Not for 2 years. Not for 5 years. For as long as he has Medicare Part D, find the creditable coverage notice your insurance company is required to send you each year. It is typically 1 page. It will say either that your coverage is creditable or that it is not. If it says it is not creditable, you need Part D the moment you turn 65. If you cannot find the notice, call your insurance company directly and ask them to confirm in writing whether your drug coverage meets the Medicare creditable coverage standard. Get that confirmation in writing. Keep it. Date it. If they are wrong and you face a penalty later, written confirmation is your only basis for an appeal. Number 4, your Medicare premium is not based on what you earn now. It is based on what you earned 2 years ago. And the year most people earn the most is often the year they retire. Medicare Part B premiums are not the same for everyone. They are adjusted based on income through a system called the Income-Related Monthly Adjustment Amount. Here is the mechanism. The Social Security Administration reviews your federal tax return from 2 years prior to determine which premium bracket you fall into. If your income that year exceeded certain thresholds, you pay a higher monthly premium. The higher the income, the higher the bracket, the higher the premium. At the lowest standard bracket, Part B costs roughly $170 per month per person. At the highest income bracket, that same Part B coverage costs over $550 per month per person. For a married couple, the difference between the standard rate and the highest bracket is more than $9,000 per year. This affects millions of people in a specific, predictable way. The year before most Americans retire is often the year they earn the most money in their careers. Final bonuses, deferred compensation payouts, pension lump sum distributions, restricted stock vesting, severance packages. That income spike, which occurred the year before they turned 65, becomes the basis for their Medicare premium calculation for the first 2 years of coverage. Barbara Chen retired at 64 after 30 years in pharmaceutical sales. Her final year of employment included her largest performance bonus, a full vesting event on restricted stock units, and the distribution of a deferred compensation plan she had contributed to for a decade. Her total reported income that year was $412,000. She had no awareness that her Medicare premiums 2 years later would be calculated against that income figure. Her Part B premium for the first 2 years of Medicare was over $500 per month. She paid an additional $4,000 annually compared to the standard rate because of income from a year she no longer worked. There is a remedy most people never use. If your income has dropped significantly since the tax year being evaluated, you can file an appeal with the Social Security Administration requesting a lower bracket based on a life-changing event. Retirement qualifies. The form is called SSA 44. It is not complicated. The savings for people in higher income brackets can be substantial. Your insurance company will not tell you about this income lookback. They will not explain how the year you retired affects what you pay for Medicare coverage 2 years later. The transition planning conversation, if they have it with you at all, is about their product options, not about the federal premium implications of the income you earned while you were still their customer. Number 5. Medicare Advantage is not Medicare. It is a private insurance product that uses the word Medicare in its name, and the company selling it to you is almost certainly your current insurer. This is where the most money is spent. The television commercials that run on every major network during fall open enrollment, the mailers, the phone calls, the sponsored content, the celebrity endorsements. Medicare Advantage, also called Medicare Part C, is private health insurance. It is not the federal Medicare program. Private insurance companies, including United Healthcare, Humana, Aetna, and Blue Cross Blue Shield, collect a fixed monthly payment from the federal government for each person enrolled in their Medicare Advantage plan. In exchange, they agree to cover at minimum what original Medicare covers. The floor is original Medicare. What happens above that floor is determined entirely by the private insurer. Medicare Advantage plans have networks. Original Medicare does not. With Original Medicare, you can see any doctor, specialist, or hospital in the country that accepts Medicare. With Medicare Advantage, you are limited to the plan's contracted network. See a provider outside that network for a non-emergency service, and you may pay the full cost. Medicare Advantage plans require prior authorization for procedures, specialist visits, and equipment that Original Medicare approves without it. Your insurer decides what gets pre-approved and what does not. Medicare Advantage plans can exit a county entirely. When a private insurer determines that a geographic area is not profitable enough to sustain, they can withdraw from that market. Every member in that county loses their plan. Coverage ends on December 31st of that year. There is no transition assistance provided by the insurer. In 2023 and 2024, more than 2 million Medicare Advantage members were disenrolled due to plan exits across hundreds of counties in the United States. Many of those members were in the middle of active medical treatment. James and Carol Whitfield were in their early 70s when their plan exited their county in rural Georgia. Carol was in active treatment for stage 3 breast cancer. She was 3 months into a 6-month chemotherapy protocol. The plan exit was announced in September. Coverage ended December 31st. Carol had to find a new plan during the special enrollment period, establish care relationships with new providers, obtain new prior authorizations from the new insurer, and restart the approval process in the middle of chemotherapy. Her oncologist of 4 years was not in the network of any plan available in their county. Medicare Advantage markets itself by placing the word Medicare at the front of its name. It is a private product. When your insurance company calls you before you turn 65 to walk you through your options, understand that they are not offering you neutral guidance. They are offering you their product. They collect the premium, they control the approvals, they can leave your county. Original Medicare is the government program. Medicare Advantage is its private replacement. Know the difference before someone sells you one as the other. Number 6. Prior authorization does not get easier at 65. On Medicare Advantage, it gets measurably harder. The prior authorization system is the process where your doctor must request permission from your insurance company before they are allowed to perform a procedure, prescribe certain medications, or refer you to a specialist. It exists, in theory, as a cost management mechanism. In practice, it functions as a denial filter. For people on commercial employer insurance under 65, prior authorization applies to a significant but bounded set of services. For people on Medicare Advantage past 65, the scope of what requires prior authorization is dramatically broader. In 2022, the Department of Health and Human Services Office of Inspector General published an analysis of prior authorization denials in Medicare Advantage plans. They found that approximately 13% of prior authorization requests that were initially denied were later approved on appeal, meaning they were medically appropriate treatments that a doctor determined a patient needed, that an insurer said no to, that were ultimately approved only after the patient or physician fought back. Most patients do not appeal. Most patients do not know they can. The treatment is delayed or never received. The same investigation documented prior authorization review rates at certain large insurers that no physician could sustain through actual medical review. In one documented case, a single reviewer at a major insurer was approving or denying prior authorization requests at an average rate of 1 every 11 seconds across an 8-hour shift. No one reads a medical record in 11 seconds. Raymond Torres was 68 years old when his Medicare Advantage plan denied his prior authorization for spinal fusion surgery. His neurosurgeon had recommended the procedure after 2 years of documented conservative treatment, including physical therapy, epidural injections, and pain management. The denial letter cited failure to meet medical necessity criteria. No physician at the insurance company had reviewed his imaging or his treatment history in any meaningful way. He filed an appeal. The appeal process took 73 days. During those 73 days, progressive nerve compression from untreated spinal stenosis caused partial loss of mobility in his left leg. The surgery was eventually approved and performed. The nerve damage was permanent. If you are approaching 65 and considering Medicare Advantage, ask one question before you enroll. Does this plan require prior authorization for the procedures and specialist visits that are most relevant to my health history? Compare that answer to Original Medicare, which requires prior authorization for almost nothing. That comparison is the most important factor in your enrollment decision. Your insurer will not raise it. Number 7, the Coordination of Benefits clause can leave you holding a 6-figure bill after 2 insurance companies both collect your premium and both decline to pay. If you are working past 65 and you carry both employer insurance and Medicare, you have 2 coverages. That sounds like double protection. In practice, it creates a calculation gap that your insurance company has a documented history of using to their advantage. Coordination of benefits is the federal and contractual framework determining which insurer pays first and which pays second. The primary payer processes the claim and pays their portion. The secondary payer is supposed to cover toward the remaining balance, subject to their plan limits. The problem is in how secondary payment is calculated. Most employer insurance plans use what is called the carve-out method, or a variation of it. Under this method, the secondary plan does not calculate their obligation based on the actual remaining balance after the primary payment. They calculate it based on the difference between what the primary insurer paid and what the employer plan theoretically would have paid if it had been the only coverage. In plain language, the secondary plan invents an imaginary scenario in which you only had their coverage, calculates what they would have owed in that scenario, subtracts what the primary already paid, and pays the difference. In many cases, that difference is 0. Helen Kovar was 66, still working full-time, carrying Medicare Part A and Part B alongside her employer plan as secondary coverage. She underwent a major surgical procedure with a total billed cost of $94,000. Medicare, as primary, paid $41,000. Her employer plan, as secondary, calculated its obligation using the carve-out method. Under their formula, they would have paid $43,000 if they had been the only insurer. They subtracted the $41,000 Medicare had paid. Their secondary obligation was $2,040. Helen received a bill for $51,000 after 12 months of paying premiums to 2 insurance companies simultaneously. Coordination of benefits disputes are among the most complex areas in insurance coverage law. Your options after the fact are limited and expensive. Your options before you turn 65 are clear. Call your employer's benefits department and ask them one specific question. How does this plan calculate its secondary payment obligation when Medicare is primary? Ask them to reference the Coordination of Benefits clause in the plan document. Ask for the calculation method by name. Get the answer in writing. If the person you speak to does not know, request the full plan document and find the Coordination of Benefits section yourself. The language is dense. It is worth reading. What you find there is the actual contract that governs what gets paid and what does not. 7 things. 1 birthday. 1 deadline. The initial enrollment period that closes forever if you miss it. The small employer trap that leaves you uninsured when you need coverage most. The creditable coverage notice sitting in your junk mail with a permanent financial consequence attached. The income lookback that takes 2 years of your highest earnings and turns them into elevated premiums. The private insurance product with Medicare in its name that is not Medicare. The prior authorization machine that gets heavier as you get older, and the Coordination of Benefits clause that makes 2 coverages add up to almost nothing. None of these are obscure. Every one of them is in federal law, in your policy documents, in the Medicare handbook the government publishes every year. The information is technically available to anyone who knows to look for it. Your insurance company does not sit you down and walk you through them. Dennis Farber paid a permanent penalty for 16 years because no one told him the window existed. Patricia Mendez paid $38,000 out of pocket because no one told her about the small employer rule. Robert Haynes pays a permanent premium surcharge every month because no one told him what creditable coverage meant. These are not unlucky edge cases. These are the expected outcomes of a silence your insurance company has every financial reason to maintain. You now know what they expected you to miss. The Medicare Initial Enrollment Period. 7 months. It opens 3 months before the month you turn 65. Find that date. Put it somewhere you will not lose it. Act before the window closes.